先生おはようございます。山村です。
Good morning, everyone. Shall we start the talk about UKA? Our topic is about patient selection indication of UKA. Yesterday, I told about the best indication for UKA is antimedial OA. That means it's intact osteoarthritis, the bone and cartilage wear is limited in the anterior part of medial tibial plateau. So how to decide, how to evaluate the ATS integrity and ATS status? So normally you imagine that so it is evaluated with manual tests like anterior drawer test and Lachman test and MRI stress anterior drawer stress test and arthroscope. But in Oxford group, recommend to evaluate SS status using trace X-ray in 20-degree reflection and inclined X-ray beam approximately 10 degrees, and then X-ray beam cut to parallel to the tibial joint surface and apply Vargas and Beta stress at 20 degrees inflection. So in Vargas stress, we can see the bone appearance in the medial side, and the Vargas stress, we can recognize the lateral normal cartilage and the corrector Vegas. That means the joint surface of the femur and tibia are parallel to each other. And Rosenberg view. This is a really nice view too. We can find the both medial side bone and the lateral side normal cartilage. So, and the biomet provides standardized assessment tool, so-called radiological decision aid. We can get this tool via internet. So it includes 5 criteria. And if the patient matches the criteria, so the patient can get good outcomes. And according to the radiological decision aid, around how patients match to this criteria of UKA. So in summary, we can do at least 5 patients. We can do the unicompartmental arthroplasty, but in fact, less than 10% patient underwent UKA so far. But we should increase the percentage of UKA. So I will explain the 5 items. Item 1, the medial size bone and bone. It's quite simple. It can be seen in AP weight bearing or stress X-ray in 20 degrees reflection or Rosenberg view. At least one view we should recognize, we should find the complete media side bond. Otherwise, in this case, is a partial thickness cartridge waves. Never do the UKA for such patient because in this patient, the cause of pain is not only the medial-sized osteoarthritis, but also hip disease or spinal disease. We should find other source of pain. So another paper showed that if we do the UKA for such patient that have not bone-on-bone appearance, the outcome is not good. It's poorer than the patient with medial-sized bone. So, but it is our topic. Basically, medial side bone on bone or lateral side bone is mandatory to do the UKA. But in fact, there are some patients such as the unrepairable meniscus tear, such as a radial tear, the posterior root tear, or extrusion of meniscus. Such patients, within 1 or 2 years, the patient come to the complete bone-on-bone, complete cartilage wear in the near future. If the patient have such repairable meniscus tear and continuous pain, you can do. We might do the UKA. So explain the patients more detail in detail, and the near future you will have the complete cartilage wear in the near future. So I will do the UKA. And then you can do in such patient, maybe, but it is accepted so far. But some limited surgeons try to do the UKA in such patient. And sometimes hidden for thickness cartilage loss can be found using MRI or arthroscope. So it is quite difficult to identify very local cartilage defect. Actually, this is the example of one patient in this wet mirroring X-ray. It shows as a still joint space at the medial side, but in fact in MRI, there are no cartilage there anymore. So it is quite difficult to identify the very local for thickness cartilage loss. So in such cases, MRI is very beneficial. And this is a case of unrepairable meniscus and with some remnant cartilage on the medial condyle, meniscus is already extruded completely. And this another patient has the posterior root tear. In such cases, some reports show that in such cases, within 1 or 2 years, the cartilage will worn out completely. In such patients, we can do maybe we can do in compact arthroplasty. But how to select the patient? The patient will have the complete worn out of medial cartilage or not. It is difficult to identify, but it is next topic of ours. So our UK user, how to select the patient in such patient is very important. And second item is the functional intact ACL that is evaluated using the true lateral. True lateral, that means the medial side and the lateral side. the condyle completely overlapped. So on the lateral X-ray, we will find the bone erosion on the tibial plateau. In this picture here is the cartilage where bone erosion area, and here is the bone erosion area. So the erosion is located anterior
Anh chỉ để như này thôi mà anh đặt
medial
xuống cái
condyle.
đấy là nó mất.
That implies intact ACL. On the other hand, the patient like this is the posterior side and this is the anterior side. The bone erosion is located the posterior part of the tibial plateau. That implies ACL deficiency. So anterior subluxation of the tibia. So in such cases, this is the contraindication of UKA for such patient. But sometimes we cannot identify bone erosion. So in the lateral X-ray, the tibial plateau is completely flat. In such cases, one report showed that. So in such cases, 94% of knees have intact ACL. So no erosion or erosion at the anterior part of tibial plateau implies the intact ACL. But sometimes ACL deficient ACL tear can be masked by several reasons. As a result, even this patient has anterior erosion, but in fact, MRI shows ACL deficient. There is several causes, but generally, so ACL integrity, ACL normality, and cartilage defect have a tight relationship. This graph shows the extent of cartilage defect and the location of cartilage defect and width of the posterior retained cartilage. That graph shows this graph shows the relationship of integrity of ACL and cartilage status. So if cartilage damage status increase the posterior preserved posterior cartilage, it can be shortened. The cartilage location of cartilage defect move to posterior, and length of cartilage loss increase according to the damage to the ACL. But in fact, some patients have the normal posterior cartilage, even if they have ACL deficient ACL because of soft tissue contracture, posterior osteophyte. Normally, big osteophyte here can prevent anterior dislocation of the tibia. So in such case, MRI might be helpful, but MRI can overestimate the ACL status once synovium of ACL is damaged. Joint fluid come into the ACL materials, ACL fibers, that it shows the false image of ACL deficient. So in such cases, you should wear a backup TK, or if possible, you can reconstruct ACL intraoperatively after unicompartmental arthroplasty. It is quite easy because bone tunnel can be made very easy under direct vision. So it's not difficult. So it takes only the 10 or 20 minutes after the UKA procedure. So if you ACL deficiency, it can be found some patients. So you should prepare of some tool for ACL reconstruction. UK and ACL reconstruction will have the good outcome. Okay, so this is the one item that they talk is one item is media side and bone. The second item is lateral X-ray. Please focus on the lateral X-ray and take a true lateral X-ray to identify the bone erosion area. Okay, I will talk about the next three items for the patient section. Okay, thank you for joining. Bye bye. See you tomorrow.